Okay, Adenokeratoconjunctivitis. Description. This is a disease of varying severity ranging from mild to severe. The incubation period is 4 to 10 days, and after the onset of conjunctivitis, the virus is shed for up to 12 days. The virus is highly contagious, being spread via ocular or respiratory secretions. The mode of dissemination is by direct contact with infected surface, especially towels, tissue, and tonometry prism. Particularly, care needs to be taken within an eye clinic to minimize the spread of the virus to both staff and other patients. Thankfully, the virus is fairly easily killed with topical alcohol wipes. Visual disturbance is usually secondary to multiple central subepithelial infiltrates. This typically fades over a few weeks to months. However, occasionally they persist for years following a severe infection. Symptoms. Typically, the patients present with a watery discharge and a mild to moderate burning irritation. Initially worse in one eye and is often become bilateral due to auto-inoculations of the other eye. The discharge increases over 1 to 2 days, and depending on the severity of the infections, the patient develops lid edema, red eye, photophobia, and blur. With pharyngeal conjunctival fever, PCF, there are also symptoms of an upper respiratory tract infections. PCF is characterized by the triad of follicles, fever, and pharyngitis. Sign. The key sign distinguishing adenokeratoconjunctivitis from simple bacterial conjunctivitis are watery discharge, follicular conjunctivitis, palpebral periocular or submandibular lymph nodes, and scattered murmular subepithelial corneal opacities. These have a topical areolar appearance with a central dense area surrounding by a less dense periphery. The bulbar hyperemia is purplish or pinkish, with injection usually beginning at the inner canthus then spreading laterally. Keratitis occurs in approximately 80% of cases of epidemic keratoconjunctivitis, but only approximately 30% of cases of PCF. The opacity are initially inflammatory, presumably a reaction to viral antigen. However, with time they may scar. Once present, a scar normally takes weeks to months to fade but may persist for years. Significant. Usually a self-limiting disease, but can result in some long-term increased glare and blurry of visions from persistent corneal opacity. Management. Topical treatment. Hygiene. It's important that the patient realize the highly contagious nature of the infections and is very careful with personal hygiene, especially with regards to food preparations during the infective period. The use of separate towels at home and the tissue instead of handkerchief should be encouraged. Supportive or palliative measures. Treatment is largely symptomatic and supportive, and spontaneous resolution occur within 2 weeks. Tear supplements to improve ocular comfort are often useful. Other possible measures are cold pack every 3 to 4 hours and irrigation with saline or cold water at the same interval. Betadine is being investigated as an antiseptic irrigation treatment for EKC. Therapeutic antiviral agents are ineffective against adenovirus. The use of topical steroid is controversial. They are only used when there is associated keratitis. They are of most benefit in the early stage of the disease when the opacity are inflammatory rather than scars. However, they can be tried to help fade opacity even several weeks to months after the initial infections. Aspirin or similar may be useful if the ocular discomfort is significant. Review. Recheck in 7 to 10 days or earlier if there is severe conjunctivitis or keratitis.